Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausmann. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on the Apple Podcast, Spotify, and on your favorite podcast app. Today's episode takes us to the heart of Southeast Asia as we explore the landscape of pediatric rheumatology care through the lens of an exceptional guest, Dr. Elizabeth Ang. She's one of the first pediatric rheumatologists in the region to receive formal pediatric rheumatology training. We discuss the healthcare system in Singapore, access to biologics, and cultural barriers that may play a role in the care of her patients. Although she works in Singapore, her reach extends far into the surrounding countries, including Cambodia, Vietnam, Indonesia, and Myanmar, where she trains local doctors and shares her knowledge and experience to ensure that no child with rheumatic disease goes undiagnosed or untreated. Dr. Elizabeth Ang is a senior consultant with the Division of Pediatric Allergy, Immunology, and Rheumatology at the National University Hospital in Singapore. She's a pediatric rheumatologist and also adjunct associate professor with the Yung Lu Lin School of Medicine at the National University of Singapore. She received her MBBS with honors from the National University of Singapore and then her Master's of Medicine in Pediatrics. She did her clinical fellowship in pediatric rheumatology at Boston Children's Hospital and then returned to Singapore as a clinician and teacher. Since 2022, she has served as the co-convenor of the Pediatric Rheumatology Special Interest Group within APLAR. That's the Asia Pacific League of Associations for Rheumatology. And in that role, she's significantly contributed to the training of others in pediatric rheumatology, taking into account their unique cultural, social, and economic nuances of their respective countries. Hope you enjoy this episode. Liz, I'm so happy to have you on our show.
Hi, John. I'm really happy to be here too.
Fantastic. So tell listeners a little bit about your background and how you ended up practicing pediatric rheumatology in Singapore.
Sure. So I'm Singaporean. I was born in Singapore. I did spend some time in the US, but most of my education was here. I got my medical degree in Singapore, and I did pediatric rheumatology fellowship with you, John, in Boston Children's Hospital more than 10 years ago. And then I came back to continue to serve the kids here.
Amazing. So how did you choose pediatric rheumatology? What exposure to pediatric rheumatology did you have during your training?
Oh, my word. I don't think I had any exposure to pediatric rheumatology. One thing I knew when I was a med student was that I wanted to do rheumatology. One thing I wasn't sure was whether I wanted to do that in adults or pediatrics. But I decided I wanted to do pediatrics. I thought I had lost my dream to do rheumatology until maybe year 3 of pediatric training. I realized there is such a thing as pediatric rheumatology. And then, yeah, that was it.
So were there any pediatric rheumatologists that you had met during your medical school training?
Not at all. In fact, pediatric rheumatology subspecialty accreditation in Singapore is still very young. And at that time, there were no formally trained pediatric rheumatologists in my institution.
That's incredible. So who was evaluating and taking care of kids with JIA, lupus, and other rheumatic diseases?
At that time, it would have been people who went overseas and did a bit of training in maybe allergy and immunology and observed in a few clinics in the US or in the UK in pediatric rheumatology, and they would come back and look after patients there. The lupus nephritis patients were cared for really well by the nephrologists.
Uh-huh.
But yeah, that was really how it was. Some of the trained rheumatologists went out to private practice where it's a lot harder to practice peds rheum. And
Hmm.
so they became more general pediatricians than anything else. And this is about 15, 20 years ago.
Yeah. So the people that were taking care of these patients didn't have formal like certification or training. They may have had some experience in sort of similar fields like immunology, and
Mhm.
you had the nephrologists that were taking care of some of these patients. So there was really no pediatric rheumatology. That's really interesting because as I was reading about the Singaporean health system, it sounds like it's very advanced in some ways, but I guess lacking in others. Can you tell us more a little bit about what healthcare in Singapore is like?
Sure. So Singapore's healthcare model is a mix of public and private healthcare. And the financing of healthcare is done through mainly direct government subsidies, some compulsory comprehensive savings, and then national health insurance, plus minus some supplementary private insurance. And so, as long as you're a Singaporean or a permanent resident in Singapore, you actually have access to heavily subsidized medical care. Depending on your income, it could be up to 80% of the total inpatient hospital bill.
Hmm.
And then in terms of other ways of financing healthcare for the Singaporean, it would be through compulsory individual medical savings. And that essentially consists of us having to put aside part of our income in a central government fund that can be drawn on for personal or family member healthcare.
That is so interesting. So it's like sort of the idea of the US Social Security that every time a portion of your paycheck goes to the government and is kept there with the theory that when you retire, you'll be able to draw from that pot of money. But I guess in the case of Singapore, you're able to draw from those funds when you need it for your own health or that of your family members.
Yeah, you're spot on. You've got that right. And not only do we contribute to this fund, but our employer contributes to it as well. And there is some co-payment just because they really want to emphasize a certain amount of personal responsibility for it, for our health. Yeah.
Yeah, so I guess with the idea of that, only people that need healthcare will access it because there's at least a little barrier in order to access it rather than get everything for free. And with the thought that people would overuse the healthcare system in that way.
Yeah, you seem to understand it really well.
I did my homework, Liz.
You are awesome.
So tell me a little bit about your experience. So you trained as a pediatrician. Tell me a little bit about what happens. You're in high school. Do you immediately go to medical school or do you have to go to university and then medical school? What is the training like to become a pediatrician in Singapore?
So, Singapore used to be a British colony, so we're still following very much of the British system when it comes to, say, education. So, the medical degree is an undergraduate degree. It usually happens right after the equivalent of your high school. So, we enter med school at around the age of 19. It's for 5 years. And then we come out and we do internship, after which we can decide to do a residency. Pediatric residency now takes about 5 to 6 years.
Wow.
So after that, then we have the option of doing a subspecialty. But as I mentioned earlier, subspecialty accreditation in Singapore is still very young. It's only been in the last maybe 5 to 6 years that certain specialties have been accredited within pediatrics. So that's like cardiology, nephrology, hematology, oncology, gastroenterology. And honestly, pediatric rheumatology hasn't been accredited or recognized as a subspecialty formally yet.
Okay. So then you did your pediatric residency and then decided to go to the US for additional training.
Mhm.
Tell me about sort of your experiences in dealing with, as a Singaporean, how you saw the US healthcare system and some of the similarities and differences between training in Singapore and your training in the US.
Wow. I gotta say, that's actually a hard question for me to answer because, John, you and I working in Boston, maybe because of the role I had, I didn't feel very involved in the financial part of it. We really just cared for patients. We saw them. We did our best for them. Sometimes we had to, apply for prior auth and stuff like that. But I felt really well supported. So I don't know if I can say that much about the healthcare system. One thing that struck me was that in general, patient health literacy was a lot better in the US. And that was something that I wished that we had a bit more here in Singapore.
Okay. What about access to tests and imaging and blood work? Did you find you had similar, it was similar than that in Singapore?
Yeah, fairly similar. I think Singapore is really lucky in that we have a lot compared to the people around Singapore. I can hardly think of any biologic that we don't have. And because healthcare is pretty heavily subsidized, no Singaporean will ever be denied good healthcare. I think now what has also made it a lot easier is biosimilars in pediatric rheumatology. When I first started doing pediatric rheumatology, some of the biologics would cost US about $800 to $1,000 per shot. And at the beginning, patients would have to kind of pay for that on their own because it didn't fall under what would be subsidized. But the same biologic now costs under 50 US dollars a shot. So that has changed things a lot.
That's amazing. So you trained here, and how was it going back to Singapore after having been trained here? Were you seeing the same types of diseases in Singapore than you did in Boston, or is there a different twist on rheumatic disease in Southeast Asia?
I love that question. Well, of course, to me, the big three are JIA, lupus, and dermatomyositis. And we see that in Singapore for sure. I think the lupuses do tend to be more severe here, especially the lupus nephritis. But I managed a lot of that under the nephrologist here, even before I went to the US. So thanks to that nephrologist, I felt pretty confident. A big difference was pain amp patients, pain amplification syndrome. I saw way more of that spectrum of patients in the US than in Singapore. And thankfully, I still see less here than I do in Boston. But I'm so thankful for the training I got there and the exposure because I think it's really helped me to be a lot better at it here for the few patients that I see.
Why do you think that is? Do you think it's like those patients exist in Singapore, they don't get referred to you? Or do you think that the incidence of these chronic pain syndromes may be higher in the US than they are in Singapore?
My gut feeling, and this is anecdotal, but I think there is a huge cultural component to it. My friend used to tell this joke. She said, when I was young and I had a tummy ache, my dad would just tap me on the head and say, go to school. There is nothing to gain from having a tummy ache or a headache. But, just like in long COVID and fibro, we're getting more and more maybe scientific evidence that there is a biological thing to it. It definitely still exists here. Just that because there is such a strong cultural, social component to these conditions, even if it is here, it's going to be dealt with a little differently.
It's so interesting. And, we've done some sessions about central pain syndromes here in this podcast where we sort of address a little bit of that. And it's so interesting. I'm always reminded that some countries don't have the concept of whiplash after an accident. So here in the US, I don't know, a third of people that experience, motor vehicle accidents experience whiplash and chronic like neck and back pain. And some countries just don't have that idea that to expect chronic pain in the neck or back, and thus they don't experience it. So I hear you how culture plays a big part in some of these conditions.
Yeah, it is interesting though, on one of my early trips to Vietnam, because I go there occasionally to see patients and teach. One of the first patients they showed me was a kid they couldn't figure out. She had a lot of pain. And I was able to examine her and kind of talk to her parents with an interpreter. And it was very clear to me that this was in the spectrum of central pain or amplified musculoskeletal pain syndrome. And that struck me in two ways. One, that it's not that uncommon, and that two, being able to recognize it and counsel on it actually can do a lot for the patient.
Yep. Yeah, a little bit of education goes a long way in some of these conditions.
Yeah.
What about the role of infections in rheumatology? Sort of whether infections mimicking rheumatic diseases or people that have rheumatic diseases, is there concern that they may, acquire infections? Are they more common in Singapore than here in the US?
Yeah. Singapore is quite an exception to the rest of the countries around us, which would be Southeast Asia. I mean, it's considered a developed country. It's really small and it's got a high standard of living. So infections are not that prevalent compared to other countries in Asia. In Singapore, the only thing that might be a little different is the incidence of tuberculosis. So, but in spite of that, it hasn't changed particularly the way we do pre-biologic screening. But that's not the case in a lot of the middle and low resource income countries around us. Infections always come into play either as part of the differential or as a big barrier to courageous immunosuppression.
Well put, Liz. So, you mentioned that prior to you, there weren't pediatric rheumatologists that had received formal training. And then 10 years ago or so, you came back. How has that changed? Are you still the only one that had received formal training, or have other people received training in pediatric rheumatology?
Yeah, so that I don't offend anyone, I'm trying hard to remember if before me there was anyone who might have done a year or more outside, and maybe there was one, like I mentioned, once they go to private practice, there's a lot less chance to hone your skills. So to answer your question, since I've been back, or maybe a little 1 or 2 years before I left to Boston, another hospital had invited a US trained Asian pediatric rheumatologist back to run the service in the other pediatric unit in Singapore. And I think he's doing a great job. He's trained a few under him. And then after me in my institution, there was one more person who went to the UK to do her clinical fellowship. So if I had to answer the question about how many trained pediatric rheumatologists there are in Singapore, I would say 6 to 8 for a population of about 6 million.
So you still think that there's probably a shortage?
I think it's enough.
You think it's enough?
I think
Okay.
it's enough for our aging population.
Very good. That's amazing. So, do patients have any barriers in accessing pediatric rheumatology care in Singapore, or are you guys fairly easily accessible?
I think, yeah, fairly easily accessible. And it's really improved in the last 15 years. I think the biggest barrier 10, maybe 15 years ago was still awareness. A lot of these peds room patients would go to ortho or neuro. And if the orthopedic doctor or neurologist didn't know that a referral was appropriate, then they would be in those clinics for the longest time.
Wow.
Because peds room has grown a lot and because primary care physician training has also improved a lot, I think those barriers have come down significantly.
Amazing. So, is there a long wait time to access pediatric rheumatology? Let's say a primary care doctor identifies a patient that may have JIA.
Uh-huh.
Can they see you within a few weeks?
Yeah, generally,
Ah,
yes.
amazing. That's much better than it is here and in many other places. Like some states in the US don't even have one trained pediatric rheumatologist. So you guys are far ahead than many states in the US. You hinted at a little bit, but when you see a patient in your clinic and you diagnose them with lupus or JIA or dermatomyositis,
Uh-huh.
are there cultural barriers that may influence the perception and management of these diseases? You hinted that patient education in the US was a little bit more advanced than that in Singapore. So can you tell us about what happens when you diagnose a patient with JIA?
Yeah, I would say that for the most part, it's the first time the families have heard of the condition. And then using the terms inflammation, it's not a term that's easily understood. And so it takes a while for them to understand it. So what I meant was that health literacy is a little bit lower here. It's not all the time, but it's a little bit lower here. But that's counterbalanced by the ability of the patient to accept a slightly more paternalistic approach than in the US.
Meaning you don't lay out the 10 different options and have them choose. You say, like, here's what we're going to do.
I still do lay out options, but I also, depending on the patient, might be a little bit more directive. And I found that they actually prefer that.
Yeah, I see it also in patients from Latin America that I take care of here in the US, is that they may not be as used to sort of having to choose among a wide menu of things, that they want your recommendations and I'll do what you tell me, doc, that type of thing.
And sometimes I can't help but think that that's fair. I mean, if there were so many options, why am I coming to you?
Right, you need some guidance. So a patient that you diagnose with JIA, if they need methotrexate or they need a TNF inhibitor or they need a abatacept, you can allow them access to all of those types of drugs?
Yeah. And we have anti-IL-1 as well, anakinra, and that's been around. And again, I consider Singaporeans so lucky to have that, because if there is one biologic that I hear my pediatric room friends around the region say they don't have access to, it's anti-IL-1.
That's right. And I believe in all of South America, anakinra is not approved. I don't know that canakinumab is either. So there's large parts of the world.
We see HL8.
Yeah, that's right. How are you going to treat him? I guess lots of steroids.
Yeah. Yeah.
And do you have to fight if you wanted to start TNF inhibitors on a patient with JIA right off the bat? Do you need to get permission, or, is there anybody fighting against your decisions of what medicines the patient needs?
No, not really. I think there is quite a bit of, I wouldn't say freedom, but there's a lot of trust, both intra and institution and patient with doctor. And because again, peds room is such a specialty, they will default, patient and sometimes institution will default to expert opinion. So I think that's helpful.
Amazing. And I know, in addition to your caring for pediatric patients with your rheumatic diseases, you have a big interest in medical education.
Uh-huh.
Can you tell me a little bit about some of the medical education that you've done within your own country, including trainees, but also talk about the medical education you've done in other countries in Southeast Asia?
Sure, I'd love to. I mean, that is part of why I really love my job. So I work in the university hospital, and we're in charge of, I guess, suppose you can say, creating and then carrying out the undergraduate curriculum for pediatric rheumatology, and same for pediatric residency in my institution. So I play a big part in that. And that's been really fun because I didn't really have that as part of my own training within residency, and definitely not in med school at that time. I mean, we're talking about more than 20 years ago. And then, I mean, it really was serendipitous how I got involved in medical peds room education in Southeast Asia. I think mostly in Cambodia, Vietnam, sometimes Indonesia. And it really started when I came back from fellowship. A friend had said, "Hey, Liz, now that you're back from fellowship, would you like to come to Cambodia?" And there was an NGO hospital there that was very good about training the residents and said, "You make the curriculum and you just come and teach it." And kind of what started me off. Yeah.
So, what sort of interventions or what things have you done over time?
In those countries or
Either, yeah, in those countries in specific. So, you went there once, or did you set up a program, or you keep going back for training? How does it work?
So everything there is pretty informal, right? Even in a country like Singapore, still being pretty early on in peds room training, it's even more basic in those countries. In the countries around Singapore, everything is a lot more informal. There is no accreditation, there is no formal program. And yeah, I've just learned a lot from the flexibility, resourcefulness, resilience of the people there. They're just willing to learn, even though they're not going to be accredited. They just want to help their own kids, the kids in their country. Yeah.
Amazing. And it must be incredibly challenging, both because of, the lack of resources, the infections, like you mentioned, tuberculosis, and that complicating your decisions for immunosuppression. How do they manage it?
I think they definitely keep that at the back of their mind. And so what I've learned from them is that they're a little apprehensive about starting immunosuppression, but a lot more comfortable using steroids. I don't know if that makes sense.
For better or for worse?
Yeah. Yeah. And I don't speak for all the countries around me. There are some really great pediatric rheumatologists in Southeast Asia that I learn a lot from as well.
Yeah.
Yeah.
That's interesting. And tell me about your involvement with APLAR, the Asia Pacific League of Associations for Rheumatology.
Sure. So APLAR is the Asia Pacific version of PANLAR and ULAR. And there was no fixed or ongoing pediatric rheumatology advocacy within that until about 2019 when a co-convenor was named, a lovely lady from Pakistan who is adult rheumatology trained, but also looking after the many pediatric rheumatology patients in Pakistan. And 15, 16 years ago, I was attending an online peds room course with her, and she pulled me in. I was interested in doing the education part within APLAR for pediatric rheumatology, and then got nominated as co-convenor for the pediatric special interest group within APLAR. And because of that, I've gotten to know and really learn from a lot of pediatric rheumatologists in the region who are working with a lot less than I have in Singapore, but are still doing really good work.
Got it. So is it reasonable to say, like, patients with pediatric rheumatic diseases in these lower resource countries, are they being cared for by people with some training in pediatric rheumatology, or people that have been trained in adult rheumatology who are also taking care of these children?
It really depends. The whole Asia Pacific region is so diverse. For about half, the pediatric room patients are cared for by adult rheumatologists who may or may not have had some training. Their training may consist of going to, say, Singapore for a year to do adult room and sitting in a few of my peds room clinics and then going. But, having said that, they are still amazing because they've learned from their patients. Then you've got countries where there is no peds room care at all. And they either just get a lot of steroids because the general primary care practitioner equivalent only knows how to use that. So it really depends on the country. It's so diverse.
Hmm. And for teaching, is the education that you provide virtual, like through Zoom and other platforms? Is it in person? And do you think it matters?
Oh, it definitely matters. So most of the teaching I've done is in person. I'll fly over. I might spend 2 weeks, 2 days there. I try and bring my residents for their exposure, for their learning. And then after that, I might do some Zoom things with them, either patient care consults or didactic lectures. But apart from in person being really important for all the reasons that you might think of, I think it's especially important because relationships mean a lot in this region.
Hmm.
And it's not just about imparting knowledge, it's also about having a friendship with the people there, with the doctors there. And that's something that I really enjoy. Yeah.
Amazing. I always think nowadays with the internet, everybody has access to information. And yet there's a lack of pediatric rheumatology care, even though they have sort of the, equivalent access. So I think it's this concept of like know-how. You may have the textbook knowledge of what it is, but when you're confronted with the patient, how do you choose among all that knowledge to try to understand what it is that the patient actually has and provide a treatment option for patients. So I think you're absolutely right. It's that in person with the patient training that can't be replaced in any other way.
Yeah, I think you've hit the nail on the head. Sometimes when they ask me about the patients, everything they say they want to do is what I would do. And all I'm doing for the doctors there is giving them confidence.
Amazing. So it sounds like, Liz, you've sort of brought a renaissance of pediatric rheumatology to Singapore and the countries surrounding it with your involvement in medical education and training other pediatric rheumatologists and helping trainees across multiple countries. What are some of changes or advancements you hope to see, over the next 5 to 10 years in Southeast Asia, in regards to pediatric rheumatology care?
First off, John, I'm not bringing a renaissance. I'm really just one little figure in the whole thing in Southeast Asia. There are like great clinicians around me, and being part of APLAR has taught me that. And I'm growing in appreciation for the people around here. But you asked, what are some of the changes I would love to see? I would love to see anti-IL-1. I would really love to see anti-IL-1.
Okay.
Would definitely love to see more peds room providers. And I would love for doctors, not just in Singapore, but elsewhere, to know that peds room is really exciting and fun and rewarding, and that peds room patients and conditions are eminently treatable. I think peds room might be a blind spot, just like it was kind of a blind spot for me when I was training, right? I didn't even know there was such a thing as peds room until I got more into pediatrics. And I don't think that the doctors in some countries know about how much they can do and what a difference they can make if they pulse early or if they treat aggressively, so to speak, with methotrexate in order to reduce steroids. And if they would know that, I think that in their own countries, they can make a big difference.
Amazing. And the other thing that struck me about your story, Liz, is that when many trainees come to the US to train, they often stay here, which is sort of part of the brain drain, right? So you have excellent doctors coming from all over the world to train in the US, and many of them stay in the US. And certainly, we need pediatric rheumatologists here in the US. That's another story. But what recommendations do you have for trainees that would help to alleviate, some of this burden so that they provide the care in the countries that need it most?
Well, I think you don't know what you don't know. So if you have the opportunity as a peds room trainee, get out there just for exposure. And I think the other thing I'd say is just be flexible. Training in the US might not make you fully ready to train in a country with a lot less resources, but it gives you something to aspire to. And though you can't necessarily get there if you're in a low resource income country, don't give up and make small steps forward and know that a little bit of care is still better than no care, and keep working to better care. Does that make sense?
Amazing, Liz. I love it. That's going to be the tagline for this show. Liz, it's been so wonderful to speak with you about your experiences in pediatric rheumatology in Southeast Asia, and so interesting. I'm always amazed about everything you've achieved and all the education that you've provided for people in that region. So I really commend you for your work, and thanks for taking the time to speak with us today, even though it's like close to midnight over there.
No, we're just 12 hours ahead of you, so it's 10:30.
Oh, okay. 12:30 in the evening. Still, that's past my bedtime.
Well, thank you so much for having me. I was like, what am I doing here? Everyone on your podcast is so scientific. But I want to credit all the people who have taught me. It was our mentor and attending Dr. Rob Sundell, right, who said that good clinicians are really great teachers as well. And so that's what I aspire to be.
I love it. I think you're right up there. Thanks, Liz.
You're so welcome, John. It's so good to see you again.
Well, there you have it. It's amazing to hear about how one person can bring about major change to an entire subcontinent. Thank you all for listening, downloading, and subscribing to our show, as well as for rating us with 5 stars or however many stars you think we deserve. You can find all of our show notes for this and other episodes at acronair.org, Apple Podcasts, Spotify, and on your favorite podcast app. Until next time, let's continue making the world a better place for all. And of course, stay healthy.